Okay, Kelsey, can you guys see that?
Yep, coming through. Not full screen yet, but
Okay,
great.
cool. Hi, everyone. My name is Lola. I'm the Harvard Site Coordinator for MHTTC. I'll just go over a few housekeeping items before we get started. So participant microphones will be muted at entry. If you have any questions during the event, you can use the chat. If you have any technical difficulties, you can just message me personally. This session is being recorded and it will be posted to the MHTTC and MapNet websites, as well as emailed to all participants once it becomes available. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of the month, MHTTC sends out certificates of completion that you can then submit to your particular board for continuing education credit. If you do have any more questions about continuing education credits, please contact ifisher@c4innovates.com for more information on that after the event. Again, certificates get sent out at the end of each month, so you won't be receiving it today, probably next week. These are some MHTTC acknowledgements. The MHTTC network uses language that is affirming, respectful, and recovery-oriented in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Kelsey for some introductions.
Great. Yeah, thank you, Lola. And thank you so much. We have a great group of people here joining us today. So I'm just here to introduce our speaker, Dr. Kim Muser, who is from our very own area of Boston. So we're very happy to have him speaking on this. So Dr. Muser is a professor of occupational therapy and psychological and brain sciences and a researcher at the Center for Psychiatric Rehabilitation at Boston University. And so he's also an adjunct professor of psychiatry at the Geisel School of Medicine at Dartmouth. So his research interests are in the development and evaluation of psychosocial interventions for persons with serious mental illness. He does a lot with our first episode Psychosis teams here in Massachusetts. And today we specifically have him here to talk about this very important and relevant overlap between physical health and serious mental illness, something that I think comes up a lot in people's ongoing care. So I'll hand it off to Dr. Muser to pull up his slides and get us started. But thank you for joining us today.
Great. Thank you very much, Kelsey. I will find my slides.
If you exit and click share from beginning, that might be faster.
Okay. Actually, let me just get it to the beginning of the presentation. Okay. All right. Thank you, Kelsey, for having me here, and Dr. Keshavan, and pleased to see everybody. I know there's a lot of people. I haven't looked at everybody participating, but I always appreciate meeting with this group and the time that people are giving on such a warm and a sunny day. So I'm going to be talking about medical comorbidities and strategies for supporting physical health, as well as managing comorbid disorders in people with the first episode of psychosis. Much of what I have to say is also relevant to people who have had multiple episodes, but I'm trying to tilt the material more towards earlier on in the course of the illness. To begin with my disclosures, unfortunately, you can't really see this so much virtually, but all of my clothes were made by my son, Jay Muser, who is a bespoke tailor, lives in New York and has stores in New York City. And otherwise, I don't have any other disclosures to present. First, to kind of set the stage a little bit, I'd like to talk about what do we know about the physical health of people with experiencing a first episode of psychosis. And one very informative study regarding this is a study that was based on the baseline characteristics of the participants who were in the RAISE ETP, Recovery After Initial Schizophrenia Episode, Early Treatment Program study. This was one of the two RAISE studies. It was the cluster randomized controlled trial that evaluated the Navigate program as compared to usual community services. And so it involved 34 different sites and a total of 400 people. And the sites were randomly assigned to either implement the Navigate program or to provide their usual services to individuals who had a first episode of psychosis. This particular paper was based on just the baseline characteristics, and so treatment differences were not relevant to this analysis. And so the primary focus of this particular paper was on the cardiometabolic risk in people with the first episode of psychosis. And the reason for the focus on cardiometabolic risk factors is that we know that the premature mortality for individuals with schizophrenia spectrum disorders is most inflated in terms of cardiovascular disease. That is the most common reason for death in people with a schizophrenia spectrum disorder. So this particular study involved 404 people. The average age was 22 years old. They had a median duration of untreated psychosis of a little bit over a year. So a fair number of people had been living with psychosis for significant periods of time. 71% of the sample was male, and the sample excluded, I put the direction sign in the wrong direction. They all had less than 3 months or less of prior antipsychotic treatment. And what was examined in this study was body composition and fasting lipids and glucose and fasting parameters, related to that. And it compared the physical parameters were also compared in some of the cases with the norms for the general population. And so what was found was that 26% of the sample was overweight and 22% of the sample was obese. The sample had 51% smokers, and men were more likely to be smokers than women. Now by the way, that's a pretty remarkably high rate of smoking. And if you look at all of the cardio metabolic risk factors in this study, the one that is most inflated as compared to the general population is in fact the smoking. So smoking seems to begin quite early. Some people begin smoking after they've developed schizophrenia, but the majority begin relatively early on in the course of the illness, or potentially even during the prodrome. 40% of the sample were pre-hypertensive, and 10% had hypertension. Males were more likely to have pre-hypertension than females. 57% had dyslipidemia, abnormal lipid metabolism. 16% had pre-diabetes, only 3% diabetes, so that's pretty low. Women were more likely to have diabetes, and 13% had metabolic syndrome. And the duration of untreated psychosis was correlated with a body weight, with weight, body mass index, and fat percentage, with a longer duration having a higher weight. And the duration of antipsychotic treatment was also correlated with abnormal lipid metabolism. And then last, when they compared the antipsychotic naive versus the people who had been exposed to antipsychotics, there were higher obesity rates in the people who had had prior exposure to antipsychotics. But remember, it's at most 3 months exposure. There was a higher rate of the metabolic syndrome. Of course, both of these would be expected from what we know in terms of the side effects of the antipsychotic medications. And interestingly, the people who had exposure to antipsychotics also had lower levels of hypertension. And of course, that makes sense because antipsychotic medications, in fact, do have antihypertensive properties. And in fact, they were discovered originally in an attempt to discover more effective medications for lowering blood pressure. So that's also consistent with that. So the factors, so what the reason I wanted to review this is this really shows that at first presentation for treatment or first presentation for coordinated specialty care treatment, individuals with the first episode of psychosis already have at least marginal health functioning in a number of different areas, and are engaging in a number of different lifestyle kind of things, which I'll get into shortly, which predisposes them to the development of medical illnesses. And at the same time, one of the things that's interesting is that the actual prevalence of different medical illnesses is pretty low in this sample. You know, there's was only a 3% rate of diabetes. There was a 10% rate of hypertension. These are not really high rates. And so it's important to look at first episode of psychosis as providing a potential opportunity to intervene early and to attempt to change certain lifestyle behaviors that could actually reduce the chances of them developing these other comorbid conditions. In terms of the factors contributing to poor health, well, we've talked about smoking, of course. It's important to, recognize that there are high rates of substance use disorders, which interact both with physical and mental health issues. In this sample, about half of them, about 50%, had a lifetime history of substance use disorder, either alcohol or cannabis. Somewhat lower than that, probably in the 30 to 40% range, continue to have substance use disorder over time, although precise estimates for that are not available. As is common in people with multiple episodes, most clients with the first episode of psychosis live a relatively sedentary lifestyle, in part because of the negative symptoms that are experienced, but there are other factors as well, reduced resources for engaging in other activities and the like. There is a lack of exercise. It's common for people to have poor dietary habits, and it's also common for people to have not have received appropriate preventive health care. So what are the implications of this in terms of treatment for first episode psychosis? And for now, what I'm going to do is just take a little bit of a deviation. I won't spend too much time, but what I want to do is to remind people about the problem of the premature mortality of people with schizophrenia and other serious mental illnesses, because this is the biggest implication for these health characteristics in the first episode psychosis population, that they represent an opportunity to try to bridge the gap between the extending lifespans of individuals who don't have a serious mental illness, individuals in the general population, and the significantly abbreviated lifespan of those people with serious mental illness. So this is just a picture of the whole world showing different life expectancies. And you can see if you look at North America, it's basically, in the US, it's average expectancy is over age 75. In Canada, it's even over age 80. And so, and this is just giving the, this actually just shows that the life expectancy of individuals has increased quite a bit in the last 120 years or so, from somewhere in the upper 40s to currently in the upper mid 70s to even early 80s, somewhat higher for women. And at the same time, while we're seeing this increase in individuals, in the lifespan of individuals in the general population, people with a serious mental illness have not benefited from that same increase in life expectancy. And in fact, and people have probably heard this, has really been known for, say, the last 25 years, that the gap between the life expectancy of people with in the general population and people with a serious mental illness, especially schizophrenia, is anywhere from 15 to 25 years earlier. And so there's kind of a lot of debate in terms of what's the best way of calculating that. But anyway, you look at it, even if you're talking about dying 10 or 15 years earlier, that's much earlier. And often in work with people with serious mental illness, an individual who was 50 or 55 years older has in many ways aged to seem or to be much older physically for a variety of these kind of health style reasons and the like, and effects of medication. Therefore kind of older age in effect comes at an earlier time for people with serious mental illness. And so this is just showing the difference in the gap between the mortality gap between people with schizophrenia and the general population, and how it's increased. This is just in the last 3 decades prior to 2000. This is like the odds. And so the odds of a person dying earlier were like 3.2 for people with schizophrenia compared to only 1.84. So in other words, as we're making advances in more effective treatment, as well as other kind of things, dietary improvements, exercise, and so on, in the general population, these benefits are not transferring over to individuals with serious mental illness. And then last, I just mentioned this, that cardiovascular disease is the most common cause of death. Now, this is in the general population as well, so it should be no surprise that it's also the most common cause of death in individuals with a serious mental illness. And this just has a number of states, and the bar on the far left for each state, that striped bar, that is the percentage of people who are dying from heart disease. And you can see across all the different states, it's always the highest one. I think I'm just going to skip this one. This is really just referring to, well, I said I was going to skip it and then I'm not, but it has the modifiable risk factors: obesity, smoking, diabetes, hypertension, dyslipidemia. And it shows how the rates of these are significantly higher in schizophrenia compared to the general population, as well as in bipolar disorder compared to the general population. I think I'm going to, well, this shows rates of comorbidity. So it's true that cardiovascular disease has increased, but you can see that now this is the odds ratio. So it's a little bit of a complicated thing to explain. It's the easier thing to do is to say if it's over 1, then it means that the odds or the chances of a person with a psychotic disorder having one of these conditions is greater than that of the general population. So you can see for a person with a serious mental illness, the chances, they have a greater chance of having diabetes, hypertension, heart disease, asthma, gastrointestinal diseases, and acute respiratory distress. So this slide I more or less covered already, so I won't go into details about it, but it essentially says this is an opportunity when we're working with people with the first episode of psychosis to intervene in order to help the person try to make certain lifestyle changes that could be of benefit in terms of reducing vulnerability to developing other comorbid medical conditions. Let's just talk for a moment about the mental health and physical health interactions, which is that it's important to recognize, and I'll come back to this a little bit later, that having physical health conditions can in fact interact with mental health conditions in a number of different ways. First of all, we know that for people with schizophrenia in particular, it has been known for a while that these individuals have higher pain thresholds, which means that they are less susceptible to recognizing and experiencing, and therefore reporting a pain that could be due to physical conditions. This has been studied in experimental pain conditions, and it's thought to be potentially related to dopamine and things like this. But what it means is that people may not report pain related to a physical condition until somewhat later in the course of the physical condition, when it's somewhat worse. And so this underscores the importance of routine physical evaluations, as well as a preventive care, because you can't always count on the person communicating a pain condition. There are sometimes difficulties that clients have in terms of communicating about their physical health needs. And then if you turn that kind of problem around to the other side, we also know that people with mental health problems, especially serious mental health problems, are less likely to be believed by people who are providing treatments for physical illnesses. And as a result of that, there's often a tendency for people with a serious mental illness to receive less effective and less evidence-based care for their medical conditions. And then people often also lack self-management skills for managing their physical illnesses. And of course, medication non-adherence can contribute to a worse course of physical illnesses. And there may also be issues related to self-medication of symptoms. We know that there's lots of substance use that can be explained or is motivated by things other than self-medication, such as facilitating social interactions or just as a source of pleasure or when people are bored and things like that. But certainly some degree of self-medication occurs. And self-medication we also know to be probably especially likely when the person has a significant trauma history and post-traumatic stress disorder. So we also know poor health contributes to worse symptoms. And we also know that some health conditions like diabetes can contribute to worse cognitive functioning. It's reversible, but people with abnormal blood sugar ratios and things like that can certainly experience spaciness and reduced cognitive abilities, which can appear to be cognitive challenges just related to their primary mental illness. So there's lots of interactions between actual physical health conditions and mental health as well. So if we talk now just for a little bit about lifestyle interventions. So broadly speaking, there are three different types of lifestyle interventions, or three different targets that are all worth considering, although I'll be going into some of these a little bit more than others. The first is promoting healthier diet. The second is smoking cessation. And the third is increasing activity and then exercise in particular. And exercise interventions, aside from having basic preventive, they have lots of beneficial effects in terms of both reducing vulnerability to the development of physical illnesses, also as a part of the management of a physical illness. And then there are psychiatric benefits as well in terms of improving symptoms, some growing evidence that exercise may also even contribute to improved cognitive functioning. I'm not going to be talking much or probably at all now at this point about smoking cessation for a couple of reasons. It is a very important thing to do. And we do have very effective interventions for it, especially pharmacological intervention, which when combined with smoking cessation groups has been shown to be very effective in reducing smoking in people with schizophrenia. But smoking cessation is a little bit of its own thing, and I understand you have received presentations on that before, and there's actually a great deal of expertise in terms of Eden Evans at Harvard in this very area, and Corey Cather. And so I will not go into that. I'll be talking a little bit more about lifestyle interventions, which typically target a combination of exercise as well as, to some extent, healthier diet. I'm going to skip this because I know I already have so many slides. There's no need to go into it. This is just a meta-analysis that showed that there's evidence for the effects of exercise on having modest enhancements in cognitive functioning. And there's now growing a number of studies that have looked at this in people with schizophrenia or serious mental illness. To talk a little bit about lifestyle interventions, because what I'm going to do here is I'm going to talk a little bit about lifestyle interventions, and then I'm going to talk a little bit about interventions that involve the integration of mental health self-management and physical health self-management. And then what I'm going to do is to get into the practical strategies of putting this on the table, engaging people in discussions, beginning to try to get people to be interested in targeting lifestyle changes and things like that. So that's what's going to be coming up. But if we talk about what do we know about effective lifestyle interventions, and I'm not reviewing the research here, but I can say there is good evidence from meta-analyses of around, I forget, 15 or 20, at least 15 or 20 studies targeting lifestyle interventions more broadly for the schizophrenia or serious mental illness population. There are some that have done it specifically focusing on first episode of psychosis, but not quite as many. But the idea behind these interventions is to support and to build self-determination for achieving goals, including changes in lifestyle, resilience, to enhance resilience in the face of stress, as well as to build self-efficacy, the sense that people are capable of doing things. And these interventions typically provide information about mental health and substance use and physical health. They emphasize the benefits of improved physical functioning and how to get in shape. And they provide some types of guidance on healthy diet and nutrition. Lifestyle interventions typically facilitate access to individuals who are experts in lifestyles, such as coaches at local gyms. And they also teach skills related to healthy living. And they try to create opportunities for people to experience new and healthier behaviors. This is something I'm going to get back to in terms of just strategies for putting healthy lifestyles kind of on the table in work with people with a first episode of psychosis. And also they attend to trying to engineer social supports for lifestyle change. This is another important factor that we'll come back to. There are a whole bunch of different lifestyle intervention programs for serious mental illness that have been developed and that have research. There is the Whole Health Action Management Program. It's probably wins in terms of having the best acronym. WHAM, sounds like a cool acronym, unless you're getting hit over the head somewhere. But and then there's behavioral weight loss intervention by Gail Dalmat at Johns Hopkins. There's the STRIDE intervention. There's the nutrition and exercise for wellness and recovery intervention from folks out at Threshold in Chicago. And there's the In Shape program developed by Steve Bartels and Sarah Pratt, colleagues of mine at the Geisel School of Medicine at Dartmouth. And just to give you a little bit more of a flavor for the In Shape program, I'm going to describe it a little bit, in part because it's become more broadly available, but there's been a national rollout. It's available in a number of places in Massachusetts, and there's pretty good data supporting it. And so what it does is it supports a kind of self-health actualization plan aimed at empowering people to take control over their own lifestyles and to live healthier lifestyles with a primary focus really on exercise. And so what this program includes is an individualized fitness and healthy lifestyle assessment. And then this is followed by weekly meetings with a health mentor, who is a certified fitness trainer. It includes free membership to a local fitness center, and it could be of the person's choosing. It has to do with what's available to them, of course. There is group exercise and healthy eating education. And then there are celebrations of various attainment of different milestones or goals in the program. So that's just a little bit about health promotion programs. I want to now talk, even though we know the rate of physical illnesses in people with the first episode of psychosis is relatively low, but they nevertheless occur, and they occur more often as people age. And so before getting into just the basic strategies, I want to also talk a little bit about comorbid physical and mental illness interventions in order to describe their core components and a little bit about how they work. The primary targets or the goals of these programs are to provide information about the nature of the physical and psychiatric disorders, as well as their interactions. It's an important part of these programs is the integration of physical health care and mental health care, and that includes routine preventive care for physical conditions. Teaching illness self-management strategies for both managing the mental illness as well as self-management strategies for the physical illness are core components of these programs. They typically include at least some skills for improving interactions with healthcare providers, with the notion that if you can enhance the social skills and self-efficacy of individuals for interacting effectively with healthcare providers and advocating for themselves, they will get better treatment. And then lifestyle change, lifestyle change in terms of a healthier diet, potentially lower fat, needing to monitor sugar or not have it in the case of diabetes, kind of things, and exercise, routine activity. These kinds of lifestyle changes are considered part of a treatment package for individuals with a diagnosed physical health conditions, such as diabetes, hypertension, and things like that. So lifestyle change has a lot of relevance for people either with a first episode or multiple episodes of psychosis, in that it can be both preventive, but it can facilitate the management of a coexisting physical illness as well. So I'm going to give one brief example, and the reason I'm giving this example is that it's a standardized program that targets both the teaching the illness management of people with both major psychiatric illness as well as a physical health condition. And it's a program I know very well because I was involved in helping to develop it. And it is called Integrated Illness Management and Recovery. And there are this is all standardized in a manual. And so this is a program that was essentially based on the illness management and recovery program, designed to teach individuals how to manage their psychiatric illness more effectively and in collaboration with others in order to pursue and achieve their recovery goals. And the IIMR program has 10 different topics that are delivered in either weekly groups or individual sessions. Typically for now, the current version of it, they're usually delivered for around 3 to 4 months of time. And it includes education on psychiatric and medical problems and how they're related to each other. So the IIMR program has a substantially expanded curriculum in terms of different educational handouts for around 10 different physical diseases. And so the teaching of that information is done in a tailored fashion to each of the individuals who are participating in the program. It includes training and self-management skills for managing both the psychiatric illness and the physical illness, and help in both identifying goals and monitoring steps towards goals, which are broken down in a fashion to make them more attainable, following the typical IMR approaches. The history of IMR goes back to 2004. It was developed around 2004 to 2006, and then it was pilot tested in a study involving 70 people in Nashua and 50 in Chicago. And then it was included in a large study in Boston, supported by the CMMI funds that were available in the recession back in 2012 to 2015. It was revised, and now it is currently being evaluated in a PCORI project. I know that it it has been evaluated in an RCT in Boston, and the analysis for that is being done, and is currently being evaluated in an even larger PCORI study being done in Kentucky and Tennessee. It's currently offered in at least 7 states. So the way this program works is that there's a general structure for the program, setting the agenda, review of progress towards goals, review of the previous session, establish the rationale for the skill that's being taught, engage people in the materials and the topic, practice the skill, and develop home practice assignments. And the focus is on not just telling or doing some telling, of course, but having conversations, listening before you talk, using handouts and related materials in people's lives, flexibility in terms of the teaching of the different topic areas, an emphasis on autonomy and empowerment, and empathy and validation about the challenges that people experience. And this is the curriculum for the program, which is parallel to the original IMR program, but incorporates throughout the whole program information and coping strategies for dealing with the physical illness as well. So beginning with recovery, then the brain-body connection becomes especially important here. And then practical facts on physical and mental health. This involves the fact sheets that are individualized based on whatever the conditions the person has. Then it gets into a healthy lifestyle. So you want to begin the process of helping people make lifestyle changes early on. Then it gets into using medications, social support, managing stress, dealing with persistent symptoms, relapse prevention, and getting your needs met. Those all those modules pretty much parallel the IMR program, but are adapted to incorporate physical illness self-management. I think I'm going to, there are practitioner guidelines in the manual, suggested additional resources, homework sheet assignments. And as I mentioned, the program focuses on integration in all the topics of the management of physical and mental health conditions. And it is recovery oriented like IMR is, with an emphasis on promoting growth, on autonomy, and of course, subscribing to Bill Anthony's definition of recovery, the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness and physical illness, and a focus on mastery over management of symptoms and it is in order to achieve life goals. And there's a kind of a vision of recovery that we try to promote in the very beginning that is then used to help people identify personal goals that they have and will work towards. And this is some of the ways in which we get people to start talking about how to create a vision of themselves, a vision of their lives, within the context of exploring recovery. So what is the vision of yourself? Why does it matter to you? What brings meaning to your life? What is the gap between now and your vision, meaning a vision of yourself in the future, a positive vision? What are the strengths that you can use to reach your vision? And what successful experiences have you had that you could build on? This becomes especially important and for people who are familiar with the individual resiliency training program, this overlaps a lot with the strengths focus that is provided very early in the IRT program. And it's because individuals with the first episode of psychosis, especially when they're coming into to services, have often had a lot of dispiriting, if not traumatic experiences that have shaken their sense of self-efficacy, their belief that they can have control over their lives, they can influence outcomes and the like. And of course, significant levels of depression accompanying that. And so being able to help people recognize their strengths, personal strengths that they can use and to both help them feel a little bit better about themselves, but also strengths as tools that can help people make progress towards desired changes and personal goals. and related to strengths of successful experiences. One of the things that we know about first episode of psychosis is that the more individuals have accomplished in their lives prior to experiencing a psychotic episode, overall, in general, the better their outcomes are. So people who have had more life experiences, those life experiences and the skills and the learning opportunities from those experiences can play a role in helping people improve their functioning and achieve goals after the onset of a psychosis. But being able to focus on and remember or attend to what has been learned in terms of those experiences can be part of what helps them capitalize on it. What are the key challenges? Helping people identify obstacles to achieving goals and the like. What would you need to be in place in order to help you achieve your vision? So this is now getting into kind of more specifics. What are the preconditions for it? What might you be willing to do as a next step in your vision? So this is just going off a little bit in terms of trying to figure out, getting people to talk about how they might like things to be different in their lives in terms of a vision. And then the last thing is similar to IRT, which was influenced by the Illness Management and Recovery Program. There are 4 different techniques in terms of teaching methods and the like that are used in the program. There are psychoeducational teaching strategies. Psychoeducation is kind of a broad term that refers to the interactive education of individuals, traditionally interactive around the topic of psychiatric disorders. But the interactive nature of psychoeducation can, of course, be applied to education about other disorders or even education more broadly. And so when we're talking about the use of psychoeducational teaching strategies, we're talking about teaching strategies that involve asking lots of questions, adapting language so that it is more easily understood by individuals, or that it uses terminology or vocabulary that individuals tend to use themselves. Asking questions in order to help people take the psychoeducational material and apply it and to see its relevance in their own lives. So the nature of psychoeducation is that you're expanding somebody's knowledge base or understanding of a condition, a mental health condition, or a physical health condition, by giving information in an interactive sort of way that facilitates the processing and the creation of meaning out of that information, in order for the person to then, over time, make potential modifications in their ability to manage the illness more effectively. I'll talk a little bit more about psychoeducation and why I think it's important later on, but it's certainly one of the techniques that is used in the IMR program and in the IIMR program. Then there's motivational interviewing. Motivational interviewing really has to do with helping explore with people ambivalence about making certain changes, but also explore potential connections between achieving goals and making a lifestyle behavior changes or self-management types of changes. I'll also talk a little bit more about motivational interviewing later on. CBT techniques, such as helping people make the connection between how they think about something influences how they feel and how they behave, and that there are alternatives to initial thoughts that people have, and that not every way of looking at a situation or interpretation is equally accurate. There are multiple different interpretations or ways of looking at different situations, and if people can be taught to become aware of what they're thinking in a particular situation, which is then influencing what they're feeling, they can stop and they can examine that thought and they can change it. And you could either try to change the thought, when it's just distressing or negative in some way. But I think the even more important thing to do is to help people figure out when their thoughts are accurate versus more accurate or less accurate. Often when people are thinking about something and they're having a negative feeling about it, especially anxiety, depression, guilt, often, not always, but often there is an inaccurate thought underlying it, and helping people make the connection and examine the thought, challenge it and change it when it's inaccurate can actually reduce the negative feeling. And so that's kind of at the essence of CBT. There's many other dimensions of it as well. And then skills training, helping people develop more effective repertoires or behaviors for interacting with people. In the IIMR program, one important area that we do skills training about is interacting with healthcare professionals. Now, this could be both a psychiatrist or other medication prescriber, but it could also be physical healthcare providers, with the notion that being a more socially skilled patient, so to speak, can improve the person's ability to understand information that a doctor or other healthcare provider is giving, as well as to describe, explain concerns, complaints, and things like that, and to advocate for oneself. So skills training has a role there. There's also skills training around coping strategies and other kinds of things. So now what I'm going to do is to talk a little bit about strategies for promoting lifestyle change. And these are kind of tilted towards people with a first episode of psychosis, but really they would be applicable for people with multiple episodes as well. And I'm just going to kind of run through the laundry list, but then I have slides on each of them. And so I'll go into some detail, some more than others. But the first, something that we've kind of talked about a little bit already, but linking lifestyle changes to personal goals. Second one, the integration of work on goals with all members of the treatment team. The third is trying to understand the why behind goals or the motivation that people sometimes set in terms of changing health behaviors, because sometimes people do spontaneously want to change health behaviors. But it's not enough just for a person to say they want to change it. As you'll see, it's important to try to get to the root of it, to understand the motivation behind it. Psychoeducation, I've talked about that a little bit already, but I'll get into a little bit more detail about it. Motivational interviewing strategies aimed at establishing discrepancy between goals and current behavior. I'll also talk a little bit about behavioral experiments. These are ways of helping people explore making changes in their health behavior that don't expect or require a kind of a commitment to making a change. As you'll see, we think that often the notion that you have to have a strong commitment to behavior change in and of itself can be an obstacle to it, because people are afraid that, if they change their behavior and make a commitment to it, their lives are going to be either a hell or less pleasant than they currently are, and they're afraid of that. And then the last thing is the idea of trying to create experiential opportunities for the client to try different things within the context of the therapy session. Okay, so in terms of the linking of goals to possible lifestyle changes, this really has to do with exploring with an individual, as you are working on a goal that's been set, and I'm kind of using the Navigate program as kind of a standard approach to helping people identify goals early on in treatment. Of course, goal setting is done primarily in the early sessions of IRT, but then it is also returned to a little bit later in IRT after covering some more basic education and skills. Although goal setting is done within the early sessions of IRT, the goals that people set are shared with other treatment team members and the like. And in some cases where clients are not as readily engaged in IRT, goals may be set in the context of family work or supported employment and education, or even in pharmacological treatment. But the notion being that the goal that an individual has isn't just a goal for like IRT or something. It's really a goal for participating in treatment. And that's the thing that the treatment team really has to hang on to in terms of maintaining engagement of the client over the long term. And not that, we certainly graduation from Navigate or leaving early could be a positive thing, going to college, especially if there's a continuity in treatment. But generally speaking, we know that when people drop out of first episode treatment early, they tend to have worse outcomes than if they remain in treatment. So having a kind of a glue or having something that is agreed upon by all of the treatment providers to be critical to maintaining engagement in treatment is important. And in the Navigate program, it is really seen as the shared work and support towards goals. So the exploration of potential lifestyle changes. For example, somebody wants to return to school. Somebody wants to go back to work. Somebody wants to make friends, or somebody wants to get closer to people. Somebody wants to reduce feelings of loneliness. Somebody wants to develop new leisure and recreational activities. So it's easy to imagine without going into a lot of detail. And one needs to take one's time. It's important that you don't look like you're kind of pushing something on the individual. But questions such as, returning to school or work, how might changes in things like diet and exercise facilitate returning to work? An example might be that building up one's stamina and engaging in a certain degree of like exercise and getting into a kind of routine, or changing some dietary habits might help the person in terms of increasing their energy level, which could facilitate getting into a school routine, working, and things like that. So that's just an example. There's lots of other examples. The making friends one. We know that there are a lot of exercise, different kind of activities that can be done in groups of people. This can be, from running and going to the gym and so on. And that can have dual advantages. One thing is that if somebody is engaged in some kind of an exercise, or could be a dietary type of program with other people, then by going to those places, they are meeting people with a similar interest. If you're taking a Taekwondo class and there are other people there who have an interest in Taekwondo, possibly more broadly martial arts, and so that provides opportunities for conversations and sometimes connecting with people. It also provides a support for engaging in that, and so people who have social goals may consider one can explore the role of certain lifestyle changes in connecting with people, and in effect doing double duty in terms of providing social opportunities, but also a structure and setting in which people may begin the process of making lifestyle changes. And then the advantage of there being social support within that particular setting for those lifestyle changes, something I'll be getting back to a little bit later. Of course, trying to make these connections, it's very important to you always use the Socratic method of asking questions, designed to help people consider whether there might be a connection and potential interest. We know that the Socratic method of asking questions rather than pointing out things tends to lead to greater conviction in conclusions that are reached by people, because people essentially reach them on their own. It also means that not every time you ask a question are you going to get the answer that you might hope for, but that's fine. There's always multiple opportunities to help people make connections between lifestyle changes and achieving goals. So that's that one. The second thing, I've kind of laid the groundwork for this already, but talk about it a little bit more, which is that it's important that all of the members of the community coordinated specialty services team are aware of what the client's goals are aware of what is being done in terms of making progress towards them, and are open to the potential of exploring links between client goals and lifestyle changes. So it's not just the primary clinician, such as the IRT clinician, who is in a position to make these links, but it could be other people. If, for example, somebody has a work or school goal, the SEE practitioner, supported employment education, might be in a better position to kind of explore those connections with the individual. Or if the client has certain side effects, or they have particular negative symptoms around energy and things like that, this might be a useful conversation for the psychiatrist or other prescriber to engage with a person. But this can only happen if it's really clear, if all the treatment members know what the person's goal is and where they are in terms of achieving it, and potentially even talking about lifestyle changes that might be useful, might be important for the person to try to make, and maybe even as a team to explore and strategize about who might be the best people to try to make this this connection with the client. And then the other thing in terms of integration is that to the extent that people have other medical health providers, certainly people should be getting routine physicals, medical evaluations. But if somebody does have an established health condition that needs ongoing treatment, then the incorporation of these medical health providers into the overall work that the client is doing in terms of achieving goals and things like that has an additional increase in terms of helping people make a connection between making lifestyle change and achieving a desired goal. So the third strategy we kind of referred to as understanding the why behind motivation to change. Up until this point, I've kind of been talking with the assumption that when you identify personal goals that people have, that the goals that people have are not going to be lifestyle related goals, that they're going to be more goals that are functional in nature, such as making friends, increasing leisure activities, role functioning like work and school and the like. But we also know that when you talk about people, help them come up with goals and things like that, it is common for people to sometimes identify goals. Sometimes the goal isn't a lifestyle goal per se, but it kind of implies a lifestyle change. So you might have a person might have the goal. I would say this is the most common goal that people tried to set in the early years of the illness management and recovery program. And of course, we've had to work with people around it, but the goal of losing 10 pounds, the goal of losing 15 pounds or something like that. And so generally, this is a goal that I say implicitly involves lifestyle change, because unless you're doing, the specific surgery, for reducing weight, probably the only way you're going to lose weight is by either changing what you're eating or eating less, exercising, generally doing both. So people will set these kind of goals. Lifestyle goals, it could be to have like more energy, could be to eat healthier, could be to sometimes to exercise more, lose weight, as previously mentioned. So these kind of goals do come up when you're doing goal setting with individuals with a first episode of psychosis or with multiple episodes. And there's a temptation as a clinician to breathe a sigh of relief or to be really happy. Hey, the person wants to make the change, and to go and run with it, to establish that as a goal. And here, what I'm going to do is make the case for that you want to do some more detective work when people immediately identify a lifestyle change. Before jumping on board with that and identifying that as the goal to work with, what you really want to do is to understand the nature of the motivation behind that goal in order to identify an even more impotent and an even more motivating goal, which change in lifestyle will then become a part of that, but it's not the only thing. So the idea here is to explore the reasons underlying the desire for achieving a goal. And the way to do this is essentially to ask questions of the person about, you can say something like, well, why do you want to make that change? But the easiest way to do this, and this is a really simple behavioral strategy that works whenever people want to make a change in a particular behavior or characteristic or a symptom or something like that, which is essentially to ask, if you did achieve this particular goal, how would your life be different? And that kind of question, this is a question that's aimed at getting at the meaning of the particular goal. I think I might have, well, I'm not following this all that carefully, but that's all right. And so, for example, when you say, oh, let's say a person wants to lose 15 pounds, and you say, so tell me, how would your life be different if you lost those 15 pounds? Well, there's actually a lot of different things that people might say. People will sometimes say, well, I'd feel better about myself. I'd feel I would be potentially more attractive to other people. It would make me a little bit more willing to go and introduce myself or try to meet new friends. I might be willing to try to go out, to try, dating or, to get into a closer relationship with somebody. So you might get goals, some that are related to just like self-esteem, feeling better about oneself. Some that might also be related to making better, stronger connections with people, because they would like to have more friends. They would like to have an intimate relationship or something like that. Or it could be that, sometimes people will say, I get really tired, easily, and I think I'm just lugging this extra weight around, and I think it drags me down. I feel much less energy. Or it would be that I can't keep up with my kids, now that they're like, 7 or 8 years old, spending a day with them, I get exhausted halfway through the day. I have to like take a nap or something. I think if I were in better shape, if I'd lost some weight, we're bringing in exercise or whatever, I'd be able to keep up with my kids. Or, my spouse does this, but I can't, I don't have the energy to do with it. I think if we could spend more of this time together, I wouldn't, be able to enjoy our relationship more. I realize that in these examples, I'm kind of merging into exercise types of goals as well. But what I'm saying is that the goal of reducing weight, or it could be just the goal of getting involved in exercise regularly, could have behind it very, very different kinds of motivations. And you want to have a discussion to understand the way in which the person would like their life to be different, and the way in which they imagine that their life would be different if they made this lifestyle change, because that is going to be the more motivating goal. And here's why that's important. Making these lifestyle changes is really hard. It's hard to get into an exercise routine. It's really hard to get people to start watching what they're eating and to change what they're eating. And the progress that people make when they're making lifestyle changes can be really, really gradual. And so that's why you end up getting a lot of dropout from lifestyle changes. On the other hand, if you identify a goal that is beyond the lifestyle change, like, okay, it starts off with the goal of losing weight, but what you find out is that the person wants to lose weight in order to feel less conscious about themselves and more comfortable in terms of meeting other people. Well, then what you can do is you can start working on the lifestyle change. If the goal is meeting new other people, you could also begin building up and working on the person's skills for meeting with people, places to meet with people, conversational topics, for getting into friendship types of skills, expressing empathy, trying to understand where the other person is coming from, social perception skills, things like that. So the idea is that if you have a more meaningful goal that has been identified, that is kind of beneath the surface of a lifestyle, a kind of goal, then what you could do is you can identify that more meaningful goal as the real goal that you're working towards. And then a lifestyle change, that becomes one of several different strategies that you're using to help the person achieve the goal. So the other strategies, things like identifying situations to meet people, practicing skills. And so you have a more meaningful goal that you're working towards, which is more likely to help sustain making changes in the person's lifestyle. But because it's not the only way they're trying to achieve that goal, you have other strategies as well, social skills, things like that, that are also working towards helping the person achieve the goal. And so that's why I think it's that way. Just the discouragement or just the challenges of making these really gradual lifestyle changes, those have much less vulnerability to discouraging the person from making the lifestyle changes than if the lifestyle changes are just a part of a larger set of strategies that the person is using to achieve their goals. So that's why I think it's really important to try to help the person identify a more important goal than just the lifestyle goal in order to have something more concrete to work towards. By the way, this is a little bit of an aside, but the same principle happens when it comes to helping people cope with persistent symptoms. When people have persistent depression, trouble getting out of bed and things like that. When people have chronic hallucinations and so on. Yeah, you can work with a person, have a goal of improving their coping for dealing with those persistent symptoms. But your ability to help them cope with it, with them, is going to be stronger if you get an idea of the things that they would be doing and would like to do, but can't because of the depression or the hearing of voices. So let's say you aren't really feeling really depressed and having difficulty getting out of bed and sleeping all day. So what would you be doing if you weren't so depressed? Well, I'd be doing this and that and the other thing. And then you're beginning to identify other things that you could also, you're going to help them work with depression, but you're not going to only work on their depression. You're going to also work on helping them take some kind of steps towards those other goals. Anyway, that's just a little bit of an aside. So this slide covers what I already said before. Okay, a little bit about psychoeducation. I've kind of made a little bit of the case for it, but I sometimes feel that I have to keep preaching, the importance of psychoeducation. So I've already defined what it is in terms of interactive teaching styles. But here's why psychoeducation is so important. It is critical to facilitating informed decision-making. I mean, we all believe, or I think we all do, that the ability for people to make informed decisions about the management of their mental illness, as well as if they have comorbid physical illnesses, requires them to have a certain understanding of those illnesses and of the different treatment options and even of the evidence behind those options. So if we really truly believe in the importance of informed decision making, even more than shared. I mean, the real goal is for the consumer to be directing their own treatment. Well, if we really believe that, then we need to share with them information that we have about the nature of those conditions and the principles of the management. And I kind of look at that as a basic right, and providing this information to the family members as well. And, remember that also with psychoeducation about particular disorders, very often people appreciate knowing that they're not alone, that other people have had this experience, and that these conditions are understood and that they've been studied scientifically. There are effective treatments. Often that information is really appreciated. And yeah, there's kind of issues about labels and things like that. But the advantage of a label is that it helps a person begin to get mastery over it. And so anyway, those are some of the reasons why I think psychoeducation is important. Motivational interviewing. I have a bunch of different slides because, motivational interviewing can be integrated into the treatment of so many different conditions, especially when people don't necessarily have motivation to focus on it. So, for example, motivational interviewing to make health behavior changes is a very common application, for example, like smoking cessation, substance abuse kind of things. And the same principles can apply in terms of either the management of a physical or mental illness or something along those lines. I think because people hopefully have at least a working awareness of what motivational interviewing is, and you can always look over these slides. I think I'm going to skip motivational interviewing in order to talk about one or two other strategies, and then to give a brief vignette, and then to see if there's any questions. So I'm going to skip through motivational interviewing. You know, I break it down into these 5 different steps. This is really based on the Miller and Rolnick work on motivational interviewing. I have my own kind of slant on it. The biggest change is that in my work, I've really looked at establishing personal goals as a separate step. Interestingly, they have that kind of rolled into the expressing empathy and developing a discrepancy. But let's skip through this. And now what I want to talk about here is a kind of a application, a somewhat novel application of an older CBT technique called behavioral experiments. So first I have to kind of explain what the technique is, and then explain this kind of new application of the technique to helping people make lifestyle changes. So in cognitive behavior therapy, in CBT, sometimes a person is dealing with a situation, a particular thought or belief in particular that the person has. These behavioral experiments are used in all of CBT, and they're especially used in CBT for psychosis, where people have persistent psychotic symptoms, and you're helping try to develop an awareness of the thinking and the beliefs underlying some of those symptoms, and eventually teaching them skills for examining that thinking and challenging it and changing it. And so in CBT, sometimes what happens is that a person has a particular belief about something, and there's a discussion about this belief, maybe some disputation or whatever. But the ending conclusion is that more information is needed that will shed light on the accuracy of that belief. And so it's when you need more information that the therapist essentially works out with the client a plan to conduct a behavioral experiment. And so the nature of a behavioral experiment, it's just like it's an experiment that the client is willing to do. They have enough question about the accuracy of the belief that they're willing to do it, that the experiment isn't posing a significant, a grave risk to the individual or something. You might have somebody who thinks that other people can read their minds, but they're not really sure if they can. And so then you arrange for the person to go into a waiting room. You work this all out in advance, and you decide that the person's going to engage in a particular thought which he or she believes would draw the attention of everybody in the waiting room to look at them, and then they're going to surreptitiously check, see how many people look, and if the majority of people look, well, maybe that's some support for the belief. But if the majority of people don't look, well, then maybe that's evidence against the belief. So, and that what the person is going to think is, I'm going to take off all of my clothes in this room. They're just going to think it, And so that would probably get the attention of people, and so they'll look. So you have to you work this whole thing out in advance, and it has to feel safe enough to the person that they're willing to do it. You have to figure out how the experiment will be interpreted in advance. If you don't, like, if one person in the room looks out of 10, person goes, well, he read my mind, and they go, no. So you work out the rules in advance. So that's kind of the idea behind a behavioral experiment. And then the person brings back this home assignment in, and they talk over, how it went and stuff, and what were the results. And this is a really classic way in CBT of getting people to reconsider thoughts underlying particular beliefs they have, reconsider the accuracy of them and change them. So that's what a standard behavioral experiment is. So this is a completely different, there are certain principles, but it's a very different application of a behavioral experiment. And here's the idea behind it. I kind of mentioned it earlier, but that people quite naturally have, there's a lot of ambivalence that people have about making lifestyle changes. And this also includes, things around changing substance use behaviors and things like that. And we know that there's this traditional stage-wise model, the trans-theoretical model of the stages of change. You have pre-contemplation, you're not even thinking about it. You have contemplation, you're thinking about it. You have preparation, you're making plans to change. You have action, you're making changes. And then you have maintenance, you're maintaining those changes. So the idea of the stages of change is that prior to making a change, a person reaches a conscious decision that they want to make a change. And so the idea that has guided a lot of health behavior change is that we have to convince people to make a change before we start helping them make a change. And the difficulty with that is that it plays into the ambivalence that people have. In other words, people are reluctant to make a commitment to making a change if they have a lot of concerns about what their life is going to be like once they make that change. Somebody who is a smoker or somebody who smokes a lot of pot, it may be very hard for them, especially like cannabis use, where we know there's a lot of negative consequences, but there's much less of a research literature on that. They may think that their lives are going to be intolerably boring if they stop smoking pot. Or somebody who smokes cigarettes, what are they going to do when they finish a meal or when they wake up in the morning, and so on and so forth. So that we know that people are very ambivalent and worried about changing their behaviors. And one of these worries is based on conceptions that they have or concerns that they have, that if they make a change in a lifestyle behavior, that it's going to be unpleasant, their lives are going to be less manageable, and they're going to regret it. And so the whole idea of a behavioral experiment is to recognize that people have a lot of these different kind of beliefs about what something is going to be like. And so rather than trying to get them to make a commitment to change, to actually experiment, to come up with behavioral experiments for people to experiment with making changes. And this isn't something you need to do just once, or maybe once would work, but it's something you could do repeatedly. And what you're really doing is you're approaching different kind of goals and changes that the person might like to make in a kind of a shared empirical fashion. You're kind of being scientists together, and the person might think that eating a healthy meal is not going to be it's going to make eating really unpleasant, or not having a second dessert, or not having any number of different kind of things. But the idea is that you can take on ambivalence that people may have about change and identify what the concerns are, and then develop behavioral experiments together for the person to try out and to bring back and to talk about and to process. And of course, as you can imagine, behavioral experiments could cover a wide gamut of different kind of activities. But the idea is, if you can get people to start changing their behavior in certain ways, then you're going to have something to talk about. And often concerns that people have are going to be overblown. Maybe sometimes they're going to be reasonable, but it becomes a different way of getting people to think about change, which is to experiment with changing without there being a real obligation to make those kind of changes. Okay, so that is just a little. There's more information in here about the nature of behavioral experiments, but I found them to be really kind of interesting and rich to use, and that's why I wanted to kind of share it with you. Okay, so last thought, idea, strategy is to actually use the therapeutic. I mean, I'm kind of approaching this from, you have a one-on-one therapy kind of a thing. I realize people are coming from different roles on teams, and so this may be more appropriate for some people than others or whatever, but I think it's worth considering, which is that you can use time that you're spending with the client, and this also includes time the peer support is a specialist is spending. but you could take that time and actually do some different things together. I've had some clients where it's just hard for them to sit still, and where we've actually done our regular, therapy, sessions where we've taken a walk, obviously I don't use the handout so much in those sessions, but hey, that's fine. They don't have to always be used. And so, it could be taking a walk together. It could be sharing a healthy meal or preparing a meal. It could be going to a gym. But the idea of taking advantage of the fact that you're spending time with the person to go and explore what something is like with them, I think it's something that's at least worthy of consideration. Provides a little bit of a change in the regular routine of how you're working with a person. It gives opportunities to discuss and process experiences. And so I think that can be useful. I'm going to give a really brief vignette. I didn't have time to put it on the PowerPoint, and then maybe we'll have time for a question or two. But this is a case. This is a client I worked with named Jerome. Various details have been changed to disguise the individual. This person had experienced the first episode of psychosis about 6 months before I began working with them, and I also did some work with their family. The family actually had relocated to where I was at the time because they were interested in first episode work with people with schizophrenia spectrum disorders and the like. And so the guy was 26 years old. He was a little bit overweight. He was a smoker. He drank regularly. He smoked a pot regularly. He had a lot of negative symptoms, was very withdrawn and stuff. And so when I started working with him, he identified making friends. Really a longer term goal was also having a girlfriend as his primary goals in treatment. And so I worked with him individually, and I also provided. We also had some family sessions, mainly psychoeducation. Had 4 or 5 sessions with the family, and then we would meet occasionally just to update them with things that we were doing. And so I provided psychoeducation to him and his family about first episode psychosis, about its management, about interactions with substance use and the like. And he had already reduced his pot smoking, following the episode of psychosis, and he more or less stopped smoking pot within the next several months. Although we did continue to drink, and he did some moderation of the drinking, but not a huge amount. And we also began working on kind of interpersonal skills for going out and connecting and meeting with people. And I would kind of bring up other kinds of issues, related to certain kind of lifestyle things. And one of the conversations, we came to talking about jogging, running, exercise, and things like that. And I mentioned that I was a runner. We talked a little bit about that. Turned out that he had run cross country in high school. And so we started kind of working out the idea of that, actually beginning to kind of get into shape. And so he was willing to try that because he did want to lose some weight and so on. And so he began kind of doing like regular walking and the like. And he then decided that he wanted to try jogging. And then he decided that the smoking was really interfering with the jogging. And without my prompting, he actually stopped smoking. And then he started jogging more. And we actually would sometimes go out for a run together. And for the first year, I beat the pants off of him. And then he actually started beating me, having lost some more weight. And he began going to local runs where he began meeting with people. Drinking was still a little bit of a problem, or he continued to drink, but did not really have, wasn't clearly interfering with his functioning. And sometime over the second year, he began to get a job as a delivery person. And we had these regular meetings with the family members, but that's just an example of how a number of changes in lifestyle occurred in the context of one person that I worked with. Some of them were kind of deliberately targeted. Some of them that happened just by virtue of working on other goals without deliberately targeting them. And this happens to be somebody I've maintained contact with him and his family now, a good number of years later. He's actually is continuing to run. He's made more friends, but has not had a girlfriend yet. Family has continued to be supportive. So I realize I used up all of my time, but if there are any questions, I would be happy to take any.
Yeah, thank you so much, Kim. I think that's such a great note to kind of bring up right at the end, is how this really can make direct changes in someone's life, like you said, without you even having to really prompt some of that. Yeah, I've gotten a couple questions. Maybe we can go through one or two. The first one being if IMR, or really if you have any recommendations for curriculum that includes modules on things like nutrition, grocery shopping, or cooking classes.
Okay, I will make a note of that because that's important, but I don't think it's in the IMR, but I will check on that and get back to you, Kelsey, with some recommendations.
Great, yeah, and maybe we can include some of those when we post the talk as well.
Yep.
Another question, if you could give an example of a Socratic question that you might use when you're talking about these sorts of lifestyle changes with someone.
Oh, sure. Let's say somebody wants to make a friend. Do you think if you were well, you could say something like, are there particular changes that you think you could make or that you'd be interested in making that might make it easier to make friends? Or you could ask something more directly and say something like, let's say you were getting in a regular, you were exercising regularly. Do you think that would help you make friends? Or you could just ask kind of more broadly, what are the different things, what are the different kind of changes that would help you in making friends? And then you could say, oh, are there any changes in how you look that would help you make friends? Are there any changes in what you do that you think might help you make friends? So a Socratic question is really any kind of a question, as long as the clinician is leading it to get the person to consider certain things.
Great, yeah, thank you. And then my last question on here, right earlier towards the beginning, you were talking about kind of a lot of factors that contribute to people having increased comorbidities with serious mental illness. And one of those things was this idea that physicians are less likely to actually take that seriously for people who they know has a mental health diagnosis. So what are some ways, I know you mentioned social skills training, but ways that you would help people to advocate for themselves in those situations?
Well, you could approach it from two different directions. One is the client, and I think it's the best thing to do is both. But one is the client, where you're trying to increase their skills and ability to describe different concerns, conditions, symptoms, and things that they have. The second thing is when you can connect with a primary health provider or whoever is providing the treatment for the health condition, and to kind of let them know a little bit about the person's psychiatric condition, to provide a source of support, to potentially point out things that the client maybe has mentioned to you that may be brought up, but to, in effect, create a more supportive healthcare environment for the person to express their needs. It's kind of, it's similar to what sometimes happens in supported employment, where you're helping a person make a connection with a potential employer, and the person is willing to have disclosure. And you usually don't provide a lot of specific information, but the ability to kind of sell the client to the employer, in terms of what their skills are, as well as your support of the person and availability to the employer, that can often create a kind of a warmer welcoming when in an employment situation. And the same thing can happen when it comes to other healthcare providers.
Yeah, I mean, I think that that's such an important point, not just helping people advocate for themselves, but also being that advocate for them in situations where they need it.
I'll give you one kind of interesting example, but a lot of people, we assume that a person's expressiveness, how much interest they have, how expressive they are when interacting with other people. We assume that that's a monitor of their engagement or reflection of their engagement and their emotions in the situation. But we actually know that the blunting or flattening of affect that happens in schizophrenia, we know that this occurs more or less independently of the experience of emotion. So that people are connected, are having feelings with other people, but they're not showing it. And that's one of the reasons, from a skills perspective, we often teach people to try to use verbal feeling statements. You can teach them how to be a little bit more expressive, but you can't overcome it all. So we teach people to compensate verbally, but we also educate people on the other side that and not everybody has this, but when a person has flattened expression, let them know that this is not an accurate reflection of how they're feeling. And if they want to check in about how they're feeling about something, they should actually ask directly.
Well, thank you so much. I know we're right at 1 o'clock, so some people might have to sign off. I know Lola will be sending around emails with follow-up information afterwards, but thank you everybody for joining us today.
Thanks.